Today, the focus is the technologies that I love a lot, and especially focusing on melanoma diagnosis and the guidelines, because this is an important issue, because when you use something, you have to follow some rules and that are accepted by the community. Here I'm focusing on the European guidelines that are being just updated a couple of months ago. So with the focus on diagnostic devices. So you see that in Europe, we do accept that dermoscopy is something that has a very high level of evidence, because this is the first step, evaluate the evidence, the clinical and scientific evidences, and then with the level of recommendation. Just to make a brief introduction to the few of one that maybe don't know what it means. When we have a recommendation A, it means that you must use it, something that is not only recommended, that you have to use it in your clinical practice. So it's not a choice, it's kind of a strong recommendation. Recommendation B is if you have, best to use it because it's getting an advantage. Recommendation C, okay, it's an option. It's an maybe you can see and check if it's useful or not, but it's your medical advice, and you have no rule to push it to use it. So dermoscopy must to be used in Europe for diagnosis of skin tumor, and this not changed since the last time. And dermoscopy is recommended because it's well known that it increases both sensitivity and specificity. And this comes that when you have to visit a patient, a recommendation that is given is to visit the patient, not only the lesion. So usually we prefer not to accept, except for emergency triage, whatever, the single lesion, but we want to see the patient, because you may see something that the patient has suspected to be a tumor, but maybe this is just a seborrheic keratosis and the tumor is in another location or something different. And this is in order to make prevention of skin cancer. Here, just an example of a patient with some mole, seborrheic keratosis, pigmented macules, and a lesion that's without dermoscopy you cannot diagnose. Okay, so this seems to work pretty well. That's okay, fantastic. We are fantastic doctor, expert in using these technologies. But we know that every action that we do generates a reaction, generates a consequence. So that's a problem. It's a butterfly effect. Okay, we use dermoscopy, that's a butterfly that's moving the wings, and then we have a hurricane somewhere. And the hurricane is clearly this one, increment of melanoma over diagnosis. We have a high incidence growing every year for melanoma that for sure is not only related to the increased risk, it's related to a big burden of diagnosis, a huge number of excision and a huge number of biopsies because of this attention to moles. And the authors showed the cycle of melanoma over diagnosis. That's based on the patient awareness, a lower threshold of excision, dermatopathologists that are overstressed by many, big responsibility to decide if the lesion is a melanoma or not, so they get down the threshold of diagnosis, and this is giving a false positive feedback. And the recommendation of authors that are epidemiologists and not dermatologists is stop skin cancer screening, stop population-wide screening. Do you agree? So we propose on one side to visit the patient in order to get the very tiny initial melanoma. And on the other side, we have another opinion that say, stop wide screening. Don't do that. Wait the melanoma becomes visible. Wait the melanoma becomes thick. So I think that there is a balance in the middle. And the balance is given because we have still one patient dying for melanoma every day in United States, with a huge number of diagnoses of melanoma, but also a huge number of people dying for melanoma. So probably in the middle is the correct answer. So I think that the middle is linked to 3 steps. We have to identify more dangerous lesion first. Second, identify the subject at risk. And the third, most important, and that's where technology comes in, improve diagnostic accuracy. So for sure, most dangerous lesion, we know. I think that we can summarize in 2 words. We have always to pay attention, refer, and maybe, probably cut everything that's ugly, everything that's weird. Why take the risk? It's not so common. As patient at risk, we know that we have 3 categories of risk. For sure, young patient, I say young, 60 years younger because I'm 55, so in a few years probably we'll try to move the threshold, or I put at the end something like ex-young patient. So if you are a young patient and you have many moles, for sure you have to be carefully examined. Or if you have red hairs, other risk factor, MC1R mutation, family, etc. Or if you are older than 60 years and you have some damage. Not only because you have higher risk of melanoma, but also because it's impossible that you self-detect the melanoma inside this mess of altered and some damaged skin. But let's go to the improvement of diagnostic accuracy. The improvement is for sure starting from dermoscopy, but still with dermoscopy, we have a good number of benign lesions that are excised because we are not sure, we are not confident. The world is not like that, nice and ugly, and we decide. The world, there is a lot of difficult lesion, and usually when we face a difficult lesion, we recommend excision. So we need something to improve accuracy into this group of difficult lesions. This is the reflectance confocal microscopy. Reflectance confocal microscopy can increase this accuracy because it increases the confidence. Why? Because you can see cells. You have other information to be added to dermoscopy. Please, for melanoma diagnosis, don't use confocal microscopy without dermoscopy. It's a combination. First, you see in dermoscopy, you are not confident, you put confocal. And confocal gives you more information. And this information lets you decide better to excise or not. And with confocal, there is a randomized clinical trial that shows that we can save almost the 50% of unnecessary excision. And also, as it's an important thing, with safety, because the possibility to delay melanoma diagnosis is absolutely very low, and it's only for very thin melanoma. So in updated guidelines, the level of recommendation of confocal microscopy moved from 1B from 2B to 1B, and the recommendation level is B today, not anymore C. So we have a change in these new guidelines, and this is linked to the new literature and the level of recommendation. Why B? It's the same evidence of dermoscopy. Why B and not A? Because confocal microscopy costs a lot of money and it's not available everywhere. So if you have available in your surrounding, refer. If you are not sure, if you have not available, go as you are used to do. So cut, excise the lesion. That's the way, that's the reason of recommendation B, because for sure it doesn't worth to make 200 kilometers to get a confocal examination. If you have just close by, it's okay. It's a big benefit for the patient and for the system, but not if it's too long a distance. So the next step would be, I think, to reduce the cost of the technology and to make more widespread and usable these technologies. So now we have the other problem, because this is based for a lesion, but when we have a difficult patient, there I think it's very important the use of technologies like total body photography and the follow-up with digital dermoscopy. And there we have evidence that is lower, but a level recommendation that is also use it when you have it. For sure, we know that we have to combine both things, total body photography and digital dermoscopy. The first one enables to see the new melanoma. The second one enables to see the little change in lesions that were atypical. But there still we have a problem. The problem is it's an heavily time-consuming procedure. It takes, when you put it in a patient with many moles, from 30 minutes to 1 hour. And usually this kind of patients that are like leopards, many moles, they usually come in your office at 7 p.m. before the dinner. That's typical. So make a test. Take a note. You see that the last patient will be one with 200 moles. And then, so you know that you get mad and you are tired. And I think that here, new technologies, artificial intelligence can be of great help in order to minimize our risk. Today, we have technologies that enable to give a total body photography that is standardized, that is high quality, and this is with polarized light. Why it's important to polarize the light in total body photography? Because you can see better the moles, and so when you make a comparison over time, you can see better the difference, and you can see where the new mole is, and then to go and check. Also, artificial intelligence technologies help to identify this mole that you can filter and check, and you can compare over time. And this is a good help, not because it works perfectly, no, but say if there is a kind of big change, for sure it drives me to go and check that lesion with more care, so to pay more attention, so to minimize my error when I am tired. And I am tired sometimes every day. I'm Italian, so I'm born tired. And then you can make a check with digital dermoscope, and you can see also tiny changes if they correspond. For sure, you have a fantastic technology today that's a super spatial Stargate-like total body 3D imaging that I love it. It's very beautiful. For sure, it's very expensive, but it's very beautiful. And the advantage of this technology is that you have a beautiful avatar of the body, and it's an entire body, so the comparison is really fantastic. You can move in, you can see details, you can make good comparison. So this is, I think, the Ferrari of the technologies for the body mapping. For sure, you need to have the money to buy a Ferrari, because this is the cost is for sure a big limitation. So to come to the conclusion, I think that we have to think not as a single tool, but as a chain in our management of patient. We see patient, we take total body where it's needed, then it's going back. Then we take, there is something, no, it's not working. Technology, let's see. Okay, then we check with the dermoscopy, and then finally, if you have, you can make a better decision with confocal microscopy for the excision. And this is a way to change the overdiagnosis cycle in a good diagnosis cycle, because with effective monitoring of the right patient, you reduce excision and referral. With confocal microscopy, again, you can reduce excision, so you don't have the misleading feedback.